Myself Dr. Mubin Patel. I am an assistant professor in Department of Pathology, Government Medical College, Surat. Today we are going to discuss about characteristic of benign and malignant tumors. But before going through this, I would like to discuss few terminology or definitions with you. What is neoplasia? It is an abnormal mass of tissue, the growth of which exceeds and uncoordinated with that of the surrounding tissue. It persists in the same excessive manner even after stoppage of stimuli. Neoplastic and non-neoplastic, there are two types of proliferation. The non-neoplastic proliferations are controlled and reversible. That means once stimuli is over, they can revert back to its previous normal condition. There are few examples of physiological conditions like hypertrophy, hyperplasia and metaplasia. What is hypertrophy? It is increase in size of the cell which lead to increase in size of the tissue. For example, at the time of puberty, increase in glandular epithelial cells of the female breast. It is an example of hypertrophy. In hyperplasia, it is an increasing number of cells which lead to increase in volume of the tissue. Then what is metaplasia? It is reversible transformation of one type of epithelium into another type of epithelium. But the epithelium must be mature. An example of physiological hypertrophy of uterus in pregnancy. And once the delivery occurs, after a period of time, it gets back to its normal size. So it is an example of physiological hypertrophy of uterus. This is diagrammatic and microscopic image of columnar metaplasia. On the left half, we can see the presence of squamous epithelium here. In long-standing chronic esophagitis, like due to acid reflux disease or in certain other condition, this squamous epithelium may transform into columnar epithelium. So it is an example of columnar metaplasia. Also known as, in esophagus, it is also known as Barrett esophagus. Again the similar slide. It is normal esophagus lined by squamous epithelium. Long-standing inflammatory changes may lead to columnar metaplasia. If remain untreated, dysplastic changes can occur and may transform into adenocarcinoma C2 and adenocarcinoma. And come to neoplastic proliferation. These are benign and malignant lesions. They are uncontrolled and irreversible. So once they occur, they are irreversible. Even after stoppage of stimuli, they continue to grow in the same manner. In general language, it is benign means sadi gant, malignant cancer ni gant. Okay. So benign lesions are localized. It remains non-invasive for a prolonged period of time. Malignant lesion, they are spreading and can spread as well as invade to the surrounding structure. So the word cancer is derived from the Latin word crab. Means they adhere to any part and seize in an obstinate manner, similar to that of the crab. What is the mechanism of neoplasm? So it is divided into non-neoplastic and neoplastic. In non-neoplastic, that is adaptive mechanism, there is polyclonal proliferation of the cell. So for example, here two clones are there. So both clones have proliferated. So this is adaptive changes and it can get back to the normal condition once the stimuli is over. Here in neoplastic, it is monoclonal proliferation. One of the clone may proliferate. In benign condition, it is well circumscribed and non-invasive. It remains localized to that tissue. In case of malignant lesion, they invade as well as metastasis. So here we can see that it breaks the basement membrane and invade to the underlying tissue. Benign and malignant tumors can be distinguished on the basis of differentiation and anaplasia, rate of growth, local invasion and metastasis. These 4 points are very important for better understanding of benign and malignant lesion. We will see it one by one. What is differentiation? Differentiation means at which extent the neoplastic cell resemble to that of these normal parenchymal cells, both morphologically and functionally. So, for example, in well-differentiated lesion, they resemble similar to that of the normal parenchymal cell. In poorly differentiated tumor, they are poorly resembling to that of the normal tissue. And lack of differentiation is known as anaplasia. It is a hallmark of malignancy. So these are the morphological features of malignancy. By this point, we can very well differentiate between the benign and malignant lesion. Pleomorphism. What is pleomorphism? It is variation in size and shape of the cell. And if we say nuclear pleomorphism, then it is variation in size and shape of nuclei. Normally, size of the cell remains uniform throughout the tissue. But in case of malignancy, the variation is there. Abnormal nuclear morphological features, these are very important, like hyperchromasia, high NC ratio, nuclear chromatin clumping and presence of prominent nucleoli. What is hyperchromasia? The word itself says hyperchromasia. So here the staining is intense. We are using hematoxylin and eosin stain in histopathology. So if we encounter the malignant lesion, the nuclear staining is intense or dark as compared to the surrounding normal cell. So that means the nuclei is hyperchromatic. Next is high NC ratio, high nucleocytoplasmic ratio. Nucleocytoplasmic ratio is very important. Cytoplasm take the 4 or 5 size that of the nuclei. So if NC ratio is high, that means nuclei become enlarged. So this is one of the important feature. Chromatin clumping. Here, because of the malignant process and other pathogenesis, chromatin may get clumped at different places. So nuclei do not stay in the uniform chromatin. There is clumping at some places and large prominent nucleoli. Next is mitosis. In general, increased mitosis does not indicate that there is pregnancy inside. Malignancy inside. In mitosis, it just gives the proliferative rate of the tissue. Some tissue have high proliferative rate like that of the bone marrow, and some have low proliferative rate, but presence of atypical mitotic figure and bipolar, multipolar mitosis are very important to diagnose the presence of malignancy. Loss of polarity, presence of multinucleated tumor giant cells, and necrosis. Necrosis is mainly due to the growth of the tissue. The blood supply of that particular portion is not adequate, so tumor cells get necrosed, and so we can see presence of tumor necrosis in that slide. See, I have taken the slide of poorly differentiated carcinoma. It shows majority of the point we have discussed. Here, open or coarse chromatin is there within the nuclei. NC ratio is very high. You can see the large nuclei. At some places there is hyperchromatic nuclei. This is presence of prominent nucleoli. Center. presence of mitotic figure, both typical, atypical mitotic figure in increased quantity are there. Atypical mitotic figure is a very alarming sign that the tissue is malignant. Presence of multinucleated tumor giant cell. This is slide of sarcoma, rhabdomyosarcoma. Here multinucleated tumor giant cell is there. All the nuclei are hyperchromatic. Presence of bizarre cells are also there. It is not always that these tumors are benign and these tumors are malignant. There is sometimes gray zones between them. These are dysplastic lesions. They are neither benign nor malignant. It lies in the gray zone. So there is disordered growth and loss of uniformity. In dysplasia, some of the features of malignancy are present, and if untreated, it may turn into malignancy. For example, uterine cervix and colonic polyps. In uterine cervix, squamous cell carcinoma, it is not a one-step process, it is multi-step process in which presence of a series of events take place. Cervical intraepithelial neoplasia 1, 2 and 3, or we can say that mild dysplasia in second image, moderate dysplasia and severe dysplasia. Here in mild dysplasia, we can very well see that the presence of squamous epithelium, but atypical cell, see these hyperchromatic or atypical cells lie beneath the half of the epithelium. It hasn't crossed more than 50% of the epithelium. It remains to that. So it is mild dysplasia or cervical intraepithelial neoplasia 1. If untreated, it may progress to moderate dysplasia. Here we can see that it has crossed the 50% of the epithelium, but even in this slide, the upper portion is remain mature. There are no atypical cell in uppermost portion. So this is moderate dysplasia. More than 50% of the epithelium becomes dysplastic. In CIN3, in this image, full thickness of the epithelium become dysplastic. All the cells are atypical. There is no maturity at all in this epithelium, but here the basement membrane remains intact. So there is no break in the basement membrane. So we can say that it is in situ condition or carcinoma in situ. If remain untreated, it may breach this basement membrane and may transform into invasive squamous cell carcinoma. So after going through these malignancy features, some benign lesion, for example, leiomyoma. It is benign condition of uterus in which smooth muscle cells get proliferated. So there is no variation in size and shape. All are spindle-shaped smooth muscles, and they are very well defined and well encapsulated. There are many types of leiomyoma, but all are benign, and if excised, they never turn into malignant one. Next slide is thyroid adenoma. The upper portion, we can see that presence of thyroid adenoma, which is very well defined from that lower half, which is normal thyroid gland. So if surgically excised, chances of recurrence are very less. It is well defined. These both are benign lesions. Next is well differentiated squamous cell carcinoma. It is a malignant condition of original cell is squamous cell. So it is originated from squamous cell. How can we say that it is invasive or not? Here we can see that stratified squamous epithelium, presence of sheets and nest of atypical squamous cell in deeper tissue connective. Here pink laminated hyalinized material. It is also known as keratin pearl. It is a hallmark of squamous cell, not squamous cell carcinoma. Presence of keratin pearl, it only suggests that the tissue origin is squamous cell. But presence of atypia and other features we have already described. We can go to that diagnosis of squamous cell carcinoma. Next is adenocarcinoma. Adeno means gland. Glandular formation, it is similar to that of squamous cell carcinoma, but instead of squamous, here glandular proliferation is there. So all the tumor cells are arranged in glandule formation. You can see the presence of chronic inflammatory reaction in this intervening stroma, which is very common in many malignant processes. It is tissue reaction. Next feature which is very important to differentiate between benign and malignant conditions are rate of growth. કેટલી સ્પીડમાં એ ગ્રો થાય છે. Benign lesion, they are slow growing, and malignant lesions, they are rapidly growing. Benign lesion, they remain that site for many years or prolonged period of time. Even if gets untreated, it doesn't metastasize or invade. Local invasion, it is a property of malignant lesion. Benign tumors never invade the surrounding structure, and it is surrounded by fibrous capsule which separate it from the surrounding host tissue. So by the surgical excision, we can easily dissect it from the surrounding tissue, and the chances of recurrence are minimal. But there are few exceptions, like in hemangioma, the plane of well-defined cleavage plane is not there. So we may encounter difficulty while excising this. So it is a gross picture of fibroadenoma breast, which is the most common benign lesion of breast. Here we can see two colors. The yellowish color, it is normal breast tissue. Here the grayish white, well-defined homogeneous mass. This is a cut section of fibroadenoma. So well-defined homogeneous grayish white mass. Even by grossly seeing it, we can see that we can easily differentiate it from surrounding normal fatty tissue of breast. And it is well encapsulated by the capsule. This is carcinoma breast, both gross and microscopic image. Here we can very well see that this greyish white lesion is not well defined. It has invaded the surrounding yellowish fatty tissue, and if we take these sections and stain the slides, we can see the presence of tubule formation and seeds and other feature of malignancy. So this is slide of invasive ductal carcinoma breast. So gross image alone is not sufficient, but of course it may give us a clue that what is the underlying diagnosis. Squamous cell carcinoma cervix. This is gross picture, cut section of uterus and cervix. A large cauliflower proliferated grayish white growth is seen in, this is circumferential, involving all the leaves of cervix. See, microscopically, the invasive squamous cell carcinoma of cervix. So the last point is metastasis. What is metastasis? In general language, it is cancer ફેલાઈ ગયું છે. Okay, metastasis, these are tumor implant which is discontinuous with that of the primary tumor. So the new tumor is formed which is distant from to that of the primary tumor. And if metastasis occur, it unequivocally marks that the tumor is malignant, because benign neoplasm do not metastasis. But not all malignant lesions do metastasize. There are few exceptions like basal cell carcinoma. Basal cell carcinoma of the skin, this is the malignant lesion but it do not metastasize due to high apoptotic activity. So which are the route of metastasis? There are many routes. In general, sarcoma metastasizes through hematogenous or blood vessel, while carcinoma metastasizes through lymphatic routes. For example, carcinoma breast. So it is a carcinoma which spread through lymphatic channels. So while we are dealing with this carcinoma breast patient, we have to examine all the nearby lymph nodes like internal mammary, axillary, supraclavicular. So by just simple palpation we can encounter the presence of palpable lymph node, and we can examine that by biopsy, and if presence of positive lymph node is there, we can say that lymphatic metastasis is there. So TNM staging in this case will be different. So for staging, it is very important. So briefly, benign versus malignant we have already discussed. Benign, they are slow growing and expansile, while malignant lesions are fast growing and infiltrate the surrounding structure. Surface of the benign lesion are smooth and regular, very well differentiated from surrounding normal tissue, while malignant lesion on cut surface shows ulcerated, irregular or nodular area. There may be skip lesion in between them, and homogeneous, benign lesion are homogeneous, they stain grossly, they are throughout the same color, while cut section of malignant lesion shows presence of hemorrhagic necrotic area. So it becomes variegated appearance. Benign lesion, majority of the benign lesion are well encapsulated, they are surrounded by fibrous capsule which prevent the invasion, as well as which may by which it becomes easier to surgically excise that lesion. While malignant lesions, there is absence of true capsule. Sometimes capsule may be there, but it is pseudo capsule and it is partially encapsulated. So chances of recurrences are more. There is no local invasion in benign lesion. In malignant lesion, they are locally invasive to surrounding structure, as well as if they break the basement membrane, it invades the underlying connective tissue. This lesion may form ulcer, and by just gross inspection we can differentiate between the benign ulcer and malignant ulcer. The benign ulcer, the size of the benign ulcer is small, while in case of malignant it may become large. Margin is punched out in case of benign ulcer, while it is heaped up in malignant. Floor of the benign ulcer is clear, while here in malignancy it is necrotic, presence of necrotic yellowish material are there. Base of the benign ulcer is soft, while here it is indurated. In case of benign ulcer, the surrounding tissue is edematous and regular, while here it is edematous but irregular. Benign ulcer, they are superficial, so while doing scraping or surgical cleaning, they are superficial, and in case of malignancy, they are deep enough. So these are few slides of benign condition. Gross picture, the left one shows gross picture of squamous papilloma lip. It is very small in size and can get easily surgically excised. Right one is pleomorphic adenoma of salivary gland. Though it is large, but it is a benign condition. So we have to be aware that the preauricular swelling, which even becomes large, we have to get done the ultrasonography and take the excision for final diagnosis. Gross picture alone is not sufficient to diagnose the case. It may just give us the hint. The left one is follicular adenoma of thyroid gland. This adenoma, it is very well defined and encapsulated from the surrounding dark brown color thyroid tissue. Villus adenoma of rectum. These are the benign lesion. Lipoma is benign enlargement of fat, which is very common, also called as universal tumor. Hemangioma, benign condition of blood vessels. Though it is not well defined, it gets easily surgically excised. Schwannoma, it is benign enlargement of neural tissue. On cut section, shiny appearance. While doing FNSE, the patient may get complaint of tingling and pain over the sides, which is a good hint. Then comes to the malignant lesions, squamous cell carcinoma. Left one, squamous cell carcinoma foot, gross image. It looks horrible. By just seeing the gross, we can say that something wrong in this patient. But even after that, biopsy is required. Here, tongue, grayish white lesion. Basal, left image is of basal cell carcinoma, which is common in the skin near the skin of face near the inner canthus of eye. It is the malignant lesion which never metastasizes. It remains localized to that tissue. Right one is malignant melanoma. So after this discussion, let's see some terminology. It is very easy. The word oma, if there is the word oma, it means in majority case it is benign. If the suffix is carcinoma or sarcoma, these are malignant lesion. If it originates from epithelial origin, then the suffix will be carcinoma, like squamous cell carcinoma, renal cell carcinoma, transitional carcinoma. But if the tissue of origin is mesenchymal, then it is sarcoma. For example, if the tumor is mesenchymal origin, the benign condition is fibroma and the malignant condition is fibrosarcoma. Similar to that, lipoma, liposarcoma, chondroma, chondrosarcoma. So the tumor of blood vessels, benign, that is hemangioma, malignant counterpart, hemangiosarcoma. Similarly, lymphatic vessels, lymphangioma, lymphangiosarcoma. Smooth muscle, leiomyoma, leiomyosarcoma. If the origin like kidney, the benign lesion is renal tubular adenoma. The malignant lesion is renal cell carcinoma. Liver cell, it is benign condition is hepatic adenoma, hepatocellular carcinoma. Hepatocellular carcinoma is also known as hepatoma. So always there are few exceptions. Though it is hepatoma, but it is a malignant condition. If the tissue of origin is urinary tract epithelium, it is benign condition is transitional cell papilloma and the malignant condition is transitional cell carcinoma. Placenta, hydrating form mole and the malignant condition is choriocarcinoma. Tumor of melanocyte, these are benign nevi and malignant ones are malignant melanoma. So after compiling all these, thank you very much for your kind listening.